Hi, I'm Dr. Hoda Abdel-Hamid. I'm a pediatric neuromuscular neurologist. I'm an associate professor at the University of Pittsburgh School of Medicine. I'm also the director of the EMG lab and the pediatric neuromuscular program, as well as our MDA clinic here at Children's Hospital of Pittsburgh of UPMC. And today I will be talking about neuromuscular disease in the pediatric population, as well as some of the new development in treatment. And at the end, there will be a time for questions and answers. So feel free to send us your questions. The first slide is talking about what are neuromuscular disease and how they come to us. So in general, neuromuscular disease are a disease of the peripheral nervous system. They affect the peripheral nerves, muscles, neuromuscular junction, or the anterior horn cell. It's a wide range of disease, so what we call a heterogeneous group of diseases. Some of them are genetics, that's the majority, so the babies or the children are born with it, and some of them can be acquired later on or at any time because of antibodies or some kind of an immune disease that can present later on in life, so it's not considered as genetic or a congenital disease. They usually present with progressive muscle weakness, and we can talk about the presentation. So some of the referrals to our center can be due to delayed developmental milestones, mostly motor milestones, like delayed walking or abnormal gait, like toe walking, walking on the outside of the feet, or walking on the inside or internally rotating. So a lot of times that's a presentation that we see. Sometimes low tone or hypotonia can be the presenting symptom. And we will talk about some of the more common diseases that we see in the pediatric population that are mostly genetic, and they present with some of the manifestations, as I mentioned, like delayed walking or developmental delay or even motor regression. So the neuromuscular disease in general do affect different parts of the peripheral nervous system, as I mentioned, like anterior horn cell, peripheral nerves, muscles, or neuromuscular junction. So one of the common disease that we see in the pediatric population, and even though it's uncommon, but we do see it because of our catchment area, and also because we do have patients who come to us from different areas, and it's common in boys, which is called the Duchenne muscular dystrophy. It affects the boys. It's X-linked, so the mothers are usually carriers in about 70% of the cases. And then the patients present with delayed motor development, so they can be delayed walking. Most of the time they walk between 15 and 18 months. There also eventually there'll be progressive muscle weakness, and sometimes there's toe walking. So when they come to me and with these concerns, I usually, especially if it's a boy, whether or not there's a family history, one of the screening tests that we do is called the muscle enzyme testing, or called CPK, and that's usually markedly elevated. That's usually our first screening test, and sometimes it gives us a clue that this may be what's going on, and then will help guide us, which testing to do following that. And a lot of times it's genetic testing to confirm if it is indeed Duchenne muscular dystrophy, and also which genetic mutation. Because now we do have treatment options for Duchenne, and I'll talk in a little bit about the different treatment options that we have. So the Duchenne gene is pretty large. It has 79 pieces or exons, and this is one of the largest genes we have in our body. And the reason we can have, maybe that may actually contribute to the disease being not uncommon, because once a gene is large, the chances of mutation is also bigger. So you can see here, I just want to give you an idea about what genetics mean, and each part of this, or each number here, constitutes 3 different amino acids, or like 3 different parts that they have to connect together to make the gene at the end. So we need all the 79 pieces to make the protein, for the body to read it and make the protein eventually, which is also called the dystrophin protein. So you can see this is a cartoon of the dystrophin protein, and actually this is where it lies, and it connects between the outside of the cell and the inside of the cell, and acts like a bridge and kind of supports the whole cellular structure for the muscle fiber. So it's an essential protein for the muscles, and that's why Duchenne is considered one of the progressive muscular dystrophies, because once the dystrophin is absent, it causes collapse of the neighboring proteins as well, and that can explain why some of the patients, the boys, present early in life and they can have the progressive muscle weakness. So there are different types of gene glitches, or what we call mutations, that can contribute to the presentation, because one of the forms of this muscular dystrophy is also called Becker's muscular dystrophy, which is more rare, and it's a milder form. But let me explain to you, because depending on where on the gene the defect is, especially when we looked at it earlier, then we can sometimes predict whether it's going to be the milder form or the more severe form. So the milder form, what's called the Becker's, is an in-frame mutation, which means that the pieces can kind of connect together, while an out of frame causes the more severe form, which is called Duchenne. And there are different types of glitches, so it depends on if there's a whole one piece of this that's missing, or a couple of pieces, or there's double of them, what's called duplications, or even a tiny piece that's missing, that's what's called a point mutation, even introns, which is connecting pieces, or even a mutation that causes it to stop prematurely. So moving on to the next slide. I guess it's stuck here. So let me try to go on to the next slide. So some of the clinical manifestations for Duchenne muscular dystrophy include some manifestations such as delayed development, proximal muscle weakness, difficulty with walking, Gowers sign, which is difficulty getting up from the floor, or markedly elevated muscle enzymes, as I mentioned. And then we need definitely genetic testing to determine where the mutation is, such as what's called the DMD array, which is a form of genetic testing which checks the different parts of the gene and finds where the glitches are, or even a more in-depth testing such as gene sequencing, which can detect small mutations like what we call point mutations or insertions or deletions. And rarely we need a muscle biopsy, which sometimes can help us, because some mutations are difficult to find. And we've had a few patients that required a muscle biopsy, which we can stain for the dystrophin, and that if the dystrophin is absent, that tells us that this is the diagnosis, even if we can't find the mutation in the blood. And some of the mutations, I mean, of course, it's a technology. So I think with better technology in the future, this may become less and less. And definitely now we need less of the muscle biopsy. So what's the cause? Once you have a gene mutation or a glitch, this causes a downstream effect. In our case, in Duchenne muscular dystrophy, a genetic mutation or a glitch will lead to the body not being able to read the actual transcription, or will not be able to read the information that's needed to produce the protein, which causes the absent dystrophin, which is the protein we talked about, which is essential for the muscle integrity. And this leads to loss of the dystrophin associated protein complex, which is closely connected with the dystrophin, and this disrupts the calcium around the cells, or the calcium homeostasis, which invites some inflammatory cells, and this eventually causes the muscles to break down, leakage in the muscle membrane, and affecting the muscle fibers and attacking them, which causes the destruction of the muscle fibers. So we need to know what happens in the muscle, because that's what's going to guide us to provide treatment options for these patients. So one of the drugs or the treatment options that we have today is something to minimize the inflammation that's happening in the muscle. We use steroids, which is one of the common anti-inflammatory drugs. It's probably the strongest. And the steroids is the mainstay of treatment for patients with Duchenne muscular dystrophy. Until recently, it was the only drug option that we have. That had stabilized the muscle membrane to a certain degree, which had prolonged the walking in boys with Duchenne muscular dystrophy. More recently, and again, this was pursued because there are some side effects of steroids, which we all know, like weight gain, acne, short stature, and sometimes suppressing our own production of steroids. There's a new drug that has been recently approved. It's called Emflaza or deflazacort. And it was approved because it may have less side effects on patients with Duchenne muscular dystrophy. So this is one of the newer treatment options that we have. Now, a lot of times we do have to try prednisone or steroids first, the common ones that we have. And if we see side effects, then we may have to move on to this drug because it may have less side effects. It still has side effects, but it may be less, and it may be I think we need more information about it too, but this is one of the new treatment options that we have today that we can talk about. And then depending on the gene mutation, which, as we talked about, which part of the gene is affected or which glitch is affecting, then we can offer maybe genetic therapies. So gene therapy, of course, would be ideal because any time you have a genetic problem or a genetic disease, then replacing that defective gene with a new one would be ideal. But I think we're still early in the gene therapy. There are trials, which I'll talk about a little bit. But definitely that would be the ideal goal for us to do, is to do gene therapy and actually kind of or a gene transfer, so where you put in the new gene and this will help produce the protein that's missing. Then there are forms of genetic therapy which are more on the RNA level, which also helps with the transcription of the gene, which helps the reading of the gene, these are called exon skipping or stop codon read through. So actually it helps the body read through the mutation or kind of ignore the glitch and move on and make the protein, or at least a very similar protein to it. So this is what we have today. That's a couple of them have been FDA approved for patients with Duchenne muscular dystrophy, but that's more of a reason to try to pursue exactly which genetic glitch or genetic mutation the patient has, because these are mutation specific, meaning they don't work for everyone. They have to work on the patient who has this specific mutation that this drug has been manufactured for. Let me talk a little bit about exon skipping. So as we looked at the previous slides where we had all the 79 exons of the gene, so it depends on where the gene glitch is, you can actually kind of omit it and connect the pieces again. So again, to remind you, this is the DMD gene, and you can see here not all the pieces fit together. Some of them have a flat end, some have a pointy end, some have a concave end, so not all of them. So let's say we're missing exon 52. Then, you know, when the body starts reading through the different parts of the gene, and it will come here and then gets blocked. It will not be able to read through from 51 to 53. What you need to do is to connect the 50 to 53. So we need to delete that 51 or make the body jump over it. And that's what we try to do now with the exon skipping drugs. So in the patients that we have the 52 mutation, we can actually skip through 51. And we do have an approved drug. It's called exon dys 51 or eteplirsen. This received approval in 2016, and it was based on a small number of patients, but now there are many patients on it. And this was the first ever FDA-approved drug for Duchenne muscular dystrophy, and helped only the patients with mutations that were eligible for skipping exon 51. And in this case, helped about maybe 15% of the patients, or between 13 and 15% of the patients with Duchenne. It has its limitations, so this is a weekly infusion because it's not a complete gene transfer. It works on the transcription of the gene, or what we call the RNA level. And it helps read through that mutation, or like skipping over it and connecting the gene pieces together. So again, it's a smaller gene, a smaller protein, but it helps the patients function and their muscles kind of maintain the integrity of it. I think this is the first step in many of the treatment options that will come eventually. And then patients who have more recently, patients who have an exon mutation that is amenable to exon 53 skipping. There's actually just recently, just in December of 2019, there's been a recent drug that's approved for patients who are amenable to exon 53 skipping. It's called Vyondys. It's actually by the same company that produced eteplirsen, or exon Dys 51. And so far, we hope that it will continue to, again, skip over the mutation, kind of restore the reading frame, and produce a milder form of Duchenne, or a more Becker-like. This is, again, like a first step in many treatment trials or treatment options that will come available. It works on the transcription part of the gene, so it has to be injected weekly. We have to monitor for kidney functions and other parameters to make sure that it's safe and it's tolerated without side effects. And it's given through the IV, just like the exon Dys 51. Now, going on to hopefully the ideal therapy, and as we mentioned that with genetic disease, gene therapy would be probably the goal. Because with gene therapy, you're replacing the defect on the gene, and you're kind of transferring a new gene that is similar to the natural gene. However, it's not identical. This is manufactured, and you have to find a vector. So you have to kind of inject it inside a carrier. And in this case, in most gene therapies, the carrier is a virus, where we take the core of the virus out, inject it with the manufactured gene product, which carries the essential genetic information. So in the case of Duchenne muscular dystrophy, as I mentioned, the gene is formed of 79 exons, which is a rather large gene. So to put this whole gene inside a very tiny virus is difficult. So what happened is the scientists manufactured a smaller version of it, what's called a micro or a mini dystrophin. So it doesn't have all the exons, but we believe that it has the essential parts to translate, or to actually give us the essential information so the body can read it and make a protein that's very similar or close enough to the natural protein, which is dystrophin. So in this case, you have to find the vector, as I mentioned, which carries the transgene or the manufactured gene, or what in this case what we call a microdystrophin or a mini dystrophin. And the vector has to target cells with minimal immune response. So imagine you getting, sick with a little bit of the flu or cold, then your body tries to fight it. So in this case, the scientists try to find a vector or a carrier that doesn't induce the immune response. Many times we do have to suppress the immune system with a large dose of immunosuppression, such as steroids. And then this manufactured gene has to have a part linked to it, what's called a promoter, which kind of pushes it to manufacture the essential protein, which drives the expression of the intended protein in the tissues, in this case, our muscles. And hopefully, this will be enough to produce a functioning version of the missing protein. So that's the goal for gene therapy. And this is kind of the basic for other gene therapies for different genetic disease, and actually in particular for neuromuscular disease. So in this case, the mini or microdystrophin was developed because of the size of the DMD gene. It was they manufactured an abbreviated, or what's called a mini or a microdystrophin. But again, it has the essential parts for the body to read it and to produce the essential protein. And the idea is to make it a body-wide systemic gene transfer process. So you give it through the IV. and hoping that it will inject itself or like reside in the muscle cells where it actually starts producing the protein. In this case, and in many cases, it's an adeno-associated virus, where again the viral core was taken out, and the gene in question was actually transfected or put inside the covering of the virus to hopefully try to inject it. So there are different microgene configurations, and especially for Duchenne muscular dystrophy, different companies make them, different scientists have different ones with a little bit of change in each and every one, and there are different AAV types. So you may hear that there's AAV9 or AAV8, and the idea is to try to pick the one that's less immune, produces less immune response, and actually kind of helps us transfer the gene product in the body. So you may hear about different ones. So I'm going to take a break here for a second, and I'm going to move on to another disease that we see in pediatric population, again, a pediatric neuromuscular disease. So in this case, I'm moving on to spinal muscular atrophy, or SMA, which again is not an uncommon neuromuscular disease that we see in the pediatric population. And now in Pennsylvania, we do have newborn screening for SMA because we do have treatment options. So let me tell you a little bit about spinal muscular atrophy. So in case of Duchenne muscular dystrophy, it's a disease that affects the muscles. But in spinal muscular atrophy, it affects the muscles eventually, but the actual disease problem or process is actually in a very small cell inside the spinal cord called the anterior horn cell. And the anterior horn cell is kind of the mother cell for motor neurons or for motor nerves. And in this case, it's a genetic defect that the baby or the child is born with it. And there is a missing gene, which is called SMN1. So this is autosomal recessive, meaning it's inherited one piece from the mom, one piece from the dad. And when you have those two pieces missing, then you cannot make the SMN1 gene or protein. And this protein is essential for the survival of these tiny cells that we call motor neurons. But there is a second gene and a protein that actually helps them survive for a while, which is SMN2. It's very similar to SMN1, but it's lacking an exon or a piece of it. And the body kind of tries to revert that and tries to make it natural. And depending on how many copies of the SMN2 gene, then you can have more SMN2 protein, and you can help them survive for a while. So some people or some scientists looked at this, and we think that the more of SMN2 copies you have in the SMN2 protein, then the milder is the presentation of the disease. But in general, this is a progressive disease. It affects the anterior horn cell, so it prevents the information from going from the brain to the spinal cord to the peripheral nerves. And as I mentioned, this is autosomal recessive, so the mom will be a carrier, dad will be a carrier, and when the two parts of the glitch gene come together, this will form an affected child. Right. So again, this is the SMN1 protein and the SMN2, and like as I mentioned, it's missing just a piece, so it still produces some of the protein, but not all of it is functional, and that's why the more copies of the SMN2, the more functional or the less severe is the phenotype. The anterior horn cell resides right here in the spinal cord, so it's kind of the relay to all the orders of the motor neurons that come from the brain through the spinal cord, and then from it comes out the peripheral nerves to talk to the muscles. So if you're lacking this anterior horn cell, there will be no information going from the peripheral nerves to the muscles, and hence the muscle will become affected, they will be weak, and they will atrophy, so they'll become smaller. And a lot of times the presentation is, again, the baby is floppy or hypotonic or doesn't hold his head up or her head up. It can affect boys and girls equally. And a lot of times there's no family history if this is the first baby or even the second baby to the same couple, because it's an autosomal recessive disease, as I mentioned, and that's why you need two glitches to present the disease. So, and spinal muscular atrophy eventually causes muscle weakness, and that's why we need to treat it early. So luckily in Pennsylvania, as I mentioned, we do have genetic testing on the newborn screen for SMA. So this helps us with early identification. And this only started last year. And the driver for that is that now we have treatment options. So most of the time, the newborn screening may not be available unless if there is no treatment options that we can offer. But in December of 2016, there was a new drug that was approved, which helps the SMN2 copies to the body to maintain the SMN2 copies and actually make kind of more of them to make them more functional and more related to the SMN1. And this helps the survival of the motor neuron. And this helps the prolongation of life and, of course, the quality of life, and the disease itself will be less severe based on this treatment option. There was a large study that was done for this drug, and since SMA is such a severe disease without treatment, this actually helped. There was a significant improvement in the quality of life, the motor function of the babies or the children who received it, and that's why the FDA approved it. And it is given in the back, or what we call intrathecal, to try to deliver the drug to the spinal cord where the anterior horn cell is, to hopefully give it a better chance to help it survive and also be more effective. Now it is, of course, with some side effects that we have to monitor for, since this drug goes through the kidneys, so we monitor for it. It can affect the platelets, so we monitor for that. And the children will have to come initially for a more frequent visits, and after that it's usually every 4 months, but it's injected again through the CSF or the spinal cord, and we have to monitor all these parameters. But it is definitely a treatment option that's become available, and we hope that it is one of the first treatment options that will be more in the future to come. And this is giving hope to all our patients with spinal muscular atrophy, of course. So this is another treatment option that has become available, and what you're looking at here is a viral cover or a viral capsid. And if you remember, I talked a little bit about gene therapy for the treatment of Duchenne muscular dystrophy. And there is also gene therapy that's actually just recently became FDA approved for the treatment of spinal muscular atrophy, since again it's a severe disease and it presents in childhood, that we always have to be careful about gene therapy, and because it has its advantages, and we also have to look at the disadvantages. But again, because this is such a severe disease, it can be fatal if it's severe, then we have to weigh the risks and the benefits. So with gene therapy, because you're transfecting or giving the new gene again that's manufactured and injecting it through the viral vector into the body, then it's usually one and done, or but we still have to be careful about that, because not everyone will express the gene material or the gene effect the same. You can have an immune response which minimizes that. There may be side effects. And in this case, the gene therapy is not mutation dependent. And luckily in SMA, I mean, 95% of the patients have the same mutation. So in this case, it was easy. And it does kind of change the mutation or the glitch on the gene and gives you the manufactured gene. Of course, the disadvantages, as we mentioned, is immune suppression. So we usually have to use steroids or corticosteroids or some form of an immune suppression to help avoid the body fighting it and getting rid of it before it actually delivers what it's supposed to do. Because it's carried inside the vector, which is again a form of associated virus. Sometimes patients already have a high titer for it, and we check that for any patient with who is going to undergo gene therapy, whether it's for SMA or Duchenne or any other type, we check against titers against that specific vector to make sure that there's not going to be a severe immune response to it, which can cause harm or like cause an immune response that can be detrimental, or also may prevent the actual gene vector from delivering what it's supposed to do. And we don't know how long it lasts. So if you think about gene therapy a little bit like immunizations or vaccinations, sometimes we have to give boosters of it, but it may not be actually feasible in case of gene therapy. So we don't know how long it lasts. And usually it doesn't, it's very close, or at least it's close in most cases to the natural gene, but it's not, because it's manufactured, and it may not deliver or may not manifest itself in the exact same way. So the results may be different between patients. So in May of 2019, there's been a gene therapy that was approved. It's called Zolgen SMA, which helps treat the SMA. And it actually delivers the SMN1 gene, or causes, the vector carries the transfected gene, which is the SMA, and the transgene, and this will hopefully deliver a survival motor neuron that is close to the nature and helps the motor neurons to survive. And this is given through the IV. There are treatment trials that are happening. I think they will be starting soon to give it through the intrathecal to deliver a higher portion of that to the anterior horn cells where they reside in the spinal cord. So there is still more of trials and work on this that hopefully we'll be seeing in the future. So we'll take another 5 seconds break again, looking at this lovely hummingbird, and then I'm going to move on to one more disease that we do see in the pediatric population that is quite common. It's called Charcot-Marie-Tooth disease. So in this case, it's a nerve problem. So we talked about muscle, we talked about anterior horn cell. In this case, it's actually the actual peripheral nerves. So Charcot-Marie-Tooth disease is quite a common disease. There are so many different types, many genes that can cause it. It is a genetic disease. So patients are born with the genetic glitch, but the manifestations can vary. And we do follow patients and families with Charcot-Marie-Tooth disease because one of the most common ones, which is called CMT1A, is actually an autosomal dominant one. So meaning you only need one glitch on one gene to manifest it. But there are more than 40 different types of Charcot-Marie-Tooth disease, and some are more severe than others. Some can manifest earlier, some later. Some come from both sides of the family or the parents, and when the gene glitches are 2, that's when the disease manifests itself. But in general, it's a progressive disease, but not probably as fast progressing as some of the other diseases we talked about. And sometimes the parents may have the disease but don't realize it until some of their children or offsprings are diagnosed. There are many different types. Some affect the covering of the nerve, some affect the nerve itself, and of course there are different genes that can cause it. So sometimes it can be challenging to reach a specific or a definitive diagnosis for Charcot-Marie-Tooth disease from the genetic point of view. But what helps us reach a diagnosis is a nerve conduction test or an electrodiagnostic test, because this will help us localize it to the peripheral nerves. And also some of the inherited neuropathies or Charcot-Marie-Tooth disease, they can have other manifestations like in the optic nerve or in the diaphragm, or other manifestations that can help us maybe reach a definitive diagnosis as well. But all of them will have findings on the nerve conduction test, which usually is the first step. And we have options to do this in here at Children's Hospital. We have options to do with sedation because it can be an uncomfortable test, but this is usually what helps us also in the future to decide which genetic panel or which genetic route we take from this based on the findings on this test. There are some treatment options that are becoming available for Charcot-Marie-Tooth disease, mostly in the trial phase. So there is some trials for using a combination of 3 different drugs, being the baclofen, naltrexone, and sorbitol, to help patients with Charcot-Marie-Tooth disease. And the trial is actually being conducted for the type 1A. As I mentioned, this is the most common type, and it's autosomal dominant, so it can run in families. There's also a couple of other investigational drugs. One is called ACE-083, which is currently in trial, may help improve the strength and muscle mass in patients with CMT. And this is irrelevant of the type of CMT. And there's also some gene therapy trials that are happening. So I think this will gives us all hope that there are researchers, there are scientists that are looking into treatment options for some of our neuromuscular disease. So let me talk a little bit about some other forms that we would not be able to cover here because there are so many different types of neuromuscular disease. And I just wanted to mention a few. One is called Pompe disease or acid maltase, which is a form of metabolic myopathy. And we do have newborn screening for Pompe disease here in Pennsylvania. So we do follow many patients with Pompe disease. And the reason, again, it's on the newborn screen because now we have treatment options. So this is an enzyme deficiency, and there is an enzyme replacement drug for it. And it depends on when the patient manifests. So sometimes they manifest very early, what we call a neonatal or early onset Pompe disease, and those babies will need to receive the enzyme as soon as possible. And there are some late onset Pompe disease that we follow over time, and then we can decide together with the families when to initiate the treatment. There are other forms of muscle disease that we follow, and we try to reach a definitive diagnosis. And these are muscular dystrophies called limb-girdle muscular dystrophy because it affects the arms and the legs and the hip area. And they manifest with weakness, which can usually be progressive. They can have cardiac manifestations, respiratory difficulties, and there are so many different types. But usually the first step is to actually determine that this is a muscle disease and then try to find the genetic diagnosis, again, because there are some treatment trials that are happening, but depending on the type of limb-girdle muscular dystrophy, and also to reach a definitive diagnosis. And we usually, after the preliminary diagnosis, which can include blood tests to check for muscle enzymes such as CPK, and also maybe some electrodiagnostic testing such as an EMG. Occasionally we do a muscle biopsy, but at the end the definitive diagnosis is usually through genetic testing to try to find which gene is affected. A form of neuromuscular disease that can affect the nerve-muscle junction, or what we call the neuromuscular junction, is called myasthenia. There's acquired forms of it, and that's the more common we see, and this can present at any time, but the more common is young, sometimes females or young women are more affected, or they can present in a larger number compared to males. And they can have antibodies in their blood that we can detect. It can affect the eye movements, can cause ptosis or like droopy eyelids, difficulty chewing, swallowing, respiratory problems, and difficulty with muscle weakness, difficulty with gait or walking up steps. And these acquired forms, patient is usually completely normal, and then over time they develop these manifestations. And there are treatment options for it, of course, in the form of immune suppression, since this is an autoimmune disease. Now, the more rare is a congenital form, which the baby is born with the gene defect that affects the neuromuscular junction. Eventually, the diagnosis is based on genetic testing. And those sometimes can be more difficult to treat, but we do have some treatment options from a medication point of view that help improve the strength of the muscles. And then inflammatory myopathies, again, are autoimmune disease that can manifest when there's an autoimmune response from the body affecting the muscles, and can cause weakness. And those usually are diagnosed, again, by manifestations, EMG testing, muscle biopsy, MRI findings, so the combination of things. And again, the treatment is immune suppression. Congenital myopathies, which can present early with hypotonia, developmental delay, and again, we usually resort to genetic testing for that. A form of congenital myopathy that can present is a separate entity called myotonic dystrophy, which can present in a very early on, and usually there is a family history, which is because it's an autosomal dominant disease, and the moms are usually affected, and the baby is born with hypotonia, and usually there is a family history. So those we usually monitor and we look for and diagnose very early on, sometimes in the neonatal ICU if the baby is weak enough to present there. So those are some of the other neuromuscular disease. There are so many other neuromuscular disease, but I don't think the time will allow us to touch base on all of them. So since neuromuscular disease in general present with muscle weakness, which can be progressive, it can affect your breathing muscles. So depending on the type, they can present, breathing difficulties can present earlier or later. But this is a common or a general manifestation of neuromuscular disease, and we have to be aware of it. So once we reach a diagnosis, we still have to address other issues other than the muscle affection. So one of them is the pulmonary care. So in patients such as spinal muscular atrophy, we do usually refer early because their intercostal muscles or the muscles responsible for breathing can be affected early. And sometimes we use machines that can help with the coughing, such as a cough assist machine, as you see here in the slide. We usually recommend often a sleep study, especially when they're old enough to undergo that, just to see if there's any sleep disordered breathing, because at night we usually lose our tone, and that can be a manifestation at night for the sleep disorders. And occasionally we do resort to non-invasive ventilation, which can help patients to improve quality of life and sometimes prevent complications. And we do also, based on the family wishes, and we can also use invasive ventilation if needed. Another aspect to look at and never to forget is the patients with muscle disease. Some forms can have cardiac affection, since the heart is a muscle. So we have to be aware of this cardiac care and cardiac referral. Again, in certain muscular dystrophies, we do recommend early referral to monitor for dilated cardiomyopathies or irregular rhythm. And there are medications that we can offer and also monitor them along with our colleagues from the cardiac units. Orthopedic care, because of the muscle weakness. Again, this is a common finding in patients with neuromuscular disease. We have to monitor for any scoliosis or deformities of the back or the spine, which can manifest as curvature of the spine. We usually recommend spine x-rays, referral to orthopedic clinics, and a decision can be made whether or not to pursue surgeries and to perform spinal fusion, because it can affect also the breathing, because it can affect the lung capacity. Physical therapy and rehabilitation is recommended for all types of neuromuscular disease. Depending on the type, of course, we can do more or we can do less. But physical therapy, durable medical equipment such as strollers, wheelchairs, certain mattresses that help prevent bed sores, and also orthotics to help prevent contractures. And participating in physical therapy and stretching is essential for almost all types of neuromuscular disease. So we always have to remember that. Even in combination with the current treatment options that we have to remember that there are monitoring aspects that we have to keep on top of, and we have to use it in complementary to the current treatment options that we have. So it's a multidisciplinary approach. So we work very closely with our colleagues from different departments because there are different aspects to neuromuscular disease. It's not just one aspect, and we have to collaborate along with the families, the primary care, different subspecialists to try to help the patients and the families, have the best quality of life that we can offer. These are some of the studies here at Children's Hospital that we're currently participating in. They're mostly for Duchenne muscular dystrophy, which, as I mentioned, is a common type of muscular dystrophy. But if you do want to reach me, here's some of the contact information, and I'm happy to take any questions now. So I think one of the questions we have today is there a special diet recommendation for SMA and Duchenne? That's an excellent question, and I think we get asked that a lot. So there's nothing in the literature that says that there is a specific diet or certain dietary supplements that specifically help Duchenne or SMA or neuromuscular disease in general. But we do recommend a healthy diet. There are some recommendations to maybe consider a high fat and protein diet because it helps the muscles, and it has a protein component in it, and also because the carbs will may have the side effect of weight gain, which can be sometimes more of a burden for patients with neuromuscular disease in general. So the recommendation is a healthy diet. There are some supplements that we definitely recommend for neuromuscular patients, which is calcium and vitamin D, because patients with neuromuscular disease usually have thinner muscles and less intake sometimes of the essential or less manufacturing of the vitamin D, which we all need, especially here in Pennsylvania. But the calcium and vitamin D is essential supplement that I would recommend for all my patients with neuromuscular disease. And for patients even with acquired manifestations or autoimmune disease that as neuromuscular, they may benefit from vitamin D since it may have some effect on the immune system. So this is the one supplement that I would definitely, or two supplements that I would definitely recommend, which is calcium and vitamin D. The next question I have is, can a child receive both Spinraza and gene therapy for SMA treatment? Again, this is an excellent question. I think this is a question that goes through the minds of many of the parents of patients with spinal muscular atrophy. So some patients will, as we mentioned, patients will respond differently to these genetic therapies. Because every patient responds differently, our bodies are different, and some patients will do very well on one drug, but some patients may require an adjunct drug. Now, you have to understand that these genetic therapies are, they have their side effects, as we mentioned, and they also may depend on the insurance coverage. So I would advise that if someone receives one form of genetic therapy for, let's say, SMA, is to give it a chance to work, because these drugs don't work right away. And if at some point it's the doctor's decision and the family's feelings too that maybe a next step is needed, then every patient will have to be looked at separately, and we'll have to decide together if this is a better option for the patient to pursue a second form of treatment or not. And we have to be careful about the side effects and the combination, but it's definitely an option for some patients, and it may be needed in some. We have another question here. So one of the question is, if a child is diagnosed with SMA on newborn screening before symptoms start, when do you start treatment? So this is a great question, because in Pennsylvania, we do have the SMA newborn screening. Actually, in this newborn screening here in Pennsylvania, we check also the copy numbers of SMN2. But it is a progressive disease. So we do recommend treatment soon, and sooner rather than later, because it's hard to predict how the patient will manifest, whether it's going to be a milder form or a more severe form. So again, it's a collective decision between the doctor and the family, and also a long-term follow-up will have to ensue after that to see if there's any side effects. What is the best option for the patient? Do they actually benefit from the drug or not? So we do recommend starting it as soon as it's feasible, because there are some testing that needs to be done. There are some confirmation testing that need done, and also insurance authorization. So it may take a time, but actually to start the process as soon as possible. So we have another question here, and the question is, does insurance cover the cost of Spinraza and gene therapy? So that's a good question. So we all have different insurances, and some insurance companies have their policies. Most of the time, I mean, the drug will have to get insurance authorization before it's administered, because I mentioned they're rather expensive drugs, and so definitely insurance authorization will have to be sought before any treatment is, at least this type of treatment is offered. We still offer, physical therapy and everything in pulmonary care, but most insurances will cover the cost of either Spinraza or gene therapy, but the combination that is yet to be determined. I think this is, let me see. There's one more question. Do you see a big difference in the progression of DMD in the boys who receive gene therapy? So gene therapy for Duchenne muscular dystrophy is still in trial. So but there are some genetic therapies that are available, as I mentioned, like the exon skipping trial drugs that have become available. So the goal with the genetic therapy in Duchenne is to actually, especially the current therapies that we have, which is the exon skipping, is to maintain what the patient has. And if we can acquire some more muscle strength, then that's great, but it's actually to maintain what the patient has. So we do see some effect from it, and there will be newer options in the future, which may be even more effective than what we have today. But that's what we have today in combination with the therapy, the physical therapy, and the steroids and other treatment options. So I think the goal is to try to optimize the therapies together until the next set of therapies is becoming available. One question is, do the benefits of steroid in treatment of Duchenne muscular dystrophy outweigh the side effects of steroid use? And I would say, in general, yes, because we know that there is an inflammatory component to this disease based on the muscle biopsies and based also on the treatment trials that were done that show benefit from the use of steroids or some form of a steroid-like drug that help minimize the inflammatory response and stabilize the muscle membrane. So most of the trials that were done did show benefit over long term, especially prolonging walking or ambulation. So I would say yes. We do monitor the side effects very closely. So there's an eye exam, we monitor for weight gain. We can also choose the best regimen for the patient. So some patients will opt to do a daily smaller dose, or some patients opt to do a weekend higher dose, and we see what is more beneficial for the patient with the less side effects. In addition, most of the gene therapy drugs that we have to offer today do require some form of immunosuppression or steroid use prior to starting them to also help minimize the immune response. So in combination with these newer drugs, I do see some benefit as well. Of course, every patient is different, and some patient will have intolerable side effects. But I think in general, it does help the majority of patients, especially in doses that are tolerated with the least side effects. I think, let me check if there's one more. I think we have a question saying a high-fat diet is not helpful, and I assume this is for SMA. So a high-fat by itself you have to add protein to it, so there is some balance here. The problem is the only high-fat diet or ketogenic diet, which should include some protein in it. There may be some, you worry about muscle catabolism or like muscle breakdown eventually, and it may cause also problems with the high cholesterol and triglycerides in the future. So you have to be aware of like how to monitor that. So I would say a high-fat diet, maybe in combination with protein, maybe with less carbs, but not totally without carbs, may be the more beneficial. But I'm not a nutritionist, and it will also have to depend on the patient. So I think we are done with the questions. So it's been a pleasure, and I'm available at Children's Hospital for any questions or concerns, and I hope you have a great afternoon.